I want to welcome everyone to the webinar. My name is Joanna Conti, and I'm founder and CEO of Vista Research Group and also Conquer Addiction. And I have with me today Baki Martin, who is an MSW and a licensed clinical social worker and clinical director for ClearFork Academy, which is a program for adolescent boys. So he's been, has a lot of interesting things to contribute also as to how they've been using both the ongoing insight and also our data analytics, because he's one of our first users of the data analytics. So I am going to, let's see, I'm trying to move some stuff out of the way here. Okay. All right. So what I wanted to talk about today was a couple of different things. We do have a number of people on the webinar who are not currently Vista users. And so we're going to very quickly go through an overview of Vista software. And then we're going to talk about what our clients have told us that is the most effective ways that they found to use the real-time data in Insight to help individual patients. So we're going to talk about some client feedback from just in general, and then Baki is going to talk about how he's found it really helpful for some patients that he's been treating at ClearFork. Then we're going to get into the real meat of this webinar, which is how to use the aggregated data that's part of Vista's new data analytics to help you improve your overall treatment program. And I'm going to show a quick demo of the analytics, and then Baki is going to talk about some of the things that that he has learned from it and improvements that they have made in the process of making at ClearFork as a result of the use of the data analytics. Then we're going to wrap up with how you can use these kind of results to create a performance improvement plan, and then open it up for questions. So as I said at the beginning, please keep yourself muted, and you don't need to be on screen until we get to the question and answer piece, and then you only need to unmute yourself, obviously, if you are going to be asking a question. So let's go over a quick overview. We have two different types of research we provide. Our Insight product line allows you to monitor the patients while they're in treatment, so your clinicians can help those that aren't progressing well. And then we also have our Recovery 2020 product, where we follow up with the clients after they leave treatment, so that you can get the hard outcome that payers are looking for. Oh, sorry. Okay. Oh, we got more people joining us. Okay. All right. Okay, so I'm going to go now to our test drive and show you just a real quick overview of Insight Addiction and Insight Behavioral. This is what your clinicians see when they log in. They see a list of all of their patients, and some of them are flagged because they've recently reported some sort of dangerous thoughts or behaviors. If you want to see how a particular patient is doing, you click through to the patient's page. The black bar on the left is how the patient reported feeling in the 30 days before treatment, and then you can see how the patient reports improving during the time that they're in treatment. So we monitor them for depression, anxiety, trauma, suicidal intentions, self-harm, eating disorders, drug and alcohol use, the frequency and severity of cravings, how they're getting along with their family members, if they're in outpatient treatment, how frequently they're attending treatment, and finally, their satisfaction with treatment. All of the data is instantly available in real time. And one of the coolest features is our group summary reports, where you can see the most recent data point for each of your patients as a function of how long they've been in treatment. And because we label any patients in the yellow or red danger zone with their first names, a clinical director can, in a matter of moments, scroll down and see a list and see, which patients are appearing over and over again. And then they can go into their next clinical staff meeting and say, hey, let's talk about Karen and Angela, because they seem like they're really struggling. So that is an overview of our basic software. And I'm going to go back now to the software. As I said, everything we do is patient reported online. And how it works is that patients give us permission via an online questionnaire to collect their information and immediately report it back to you. They take an intake questionnaire that gives us all sorts of baseline information about how they were feeling prior to treatment and what brought them to treatment. Then the clients will report how they're feeling versus really quick update surveys, typically every week that they're in treatment. And then all of the data is provided to the clinicians in very easy to understand graphs. So how can you use Insight to help individual patients? What we found is that Insight helps clinicians identify patients who exhibit a lot of different modalities. One is if they may not be aware that they have an issue. They may, suffer from frequent flashbacks, but they may not articulate it as, I'm really feeling some traumatic symptoms until we ask them specifically, are you having repeated thoughts and flashbacks? And then they'll report, yes, in fact, actually I am. What we've heard from one of our large group of treatment centers is that Insight identified issues that they weren't previously aware of in 30 to 40% of their patients, because we start by screening all patients for depression, anxiety, trauma, eating disorders, suicidality, and self-harm. And you can also ask to have your patients screened for mania, psychosis, and functioning. Another type of patient that Insight can be very useful for is those that really aren't comfortable admitting their issues face-to-face. For a lot of patients, they're just a lot more comfortable talking to the anonymous internet than they are face-to-face. And I think most of our clinical directors have had experiences where they say, well, I asked them multiple times about that, and they never said they were suicidal. And then I get the report, and oh my goodness, they're thinking about possibly taking action. So it often will identify issues that the patient may not tell you face to face. Another area that it can be helpful is with patients whose progress has plateaued or even gone backwards. Maybe they came into treatment and they made some improvement, but then they've stayed the same place. It's easy to assume they're continuing to get better, and they may not be, and this makes it very obvious. Another issue that Insight can help with is identifying patients that are really in a bad place and are thinking about contemplating suicide. We had one of our treatment centers, a mid-sized IOP program, has told us that they are convinced that the Insight alerts that their clinicians received when a patient reported dangerous suicidal thoughts with possible intention to act, that by responding quickly to those alerts, their treatment center has been able to save the lives of 3 different patients in the last 21 months. It's also useful in identifying those patients who are at high risk of leaving AMA. If you just look at 2 features of Insight, one is how frequently they're submitting surveys, if they're an outpatient and it's really their choice. Somebody's not standing over them and saying, okay, Joe, fill this survey in now. But if it's their choice and they're deciding whether or not to respond to an email or text from us, that's an important indicator of their engagement in treatment, as is looking at the types of comments they make. We found that patients that make no comments or make predominantly negative comments, or that fill in substantially fewer surveys than is typical for their length of stay at that treatment center, that just looking at those two things will allow you to identify 79% of the patients at risk of leaving AMA. And of course, it will also identify a few patients that will successfully complete treatment, but you can use those two things to really identify those patients that are disengaged or disengaging. And then finally, it can be useful to identify patients on the verge of relapse. This was one of our earliest adolescent clients, and there was a girl in IOP treatment who came into treatment and seemed to be doing very well, and then all of a sudden, everything skyrocketed at once. And unfortunately, this treatment center wasn't set up to take action immediately. And within a couple of days of submitting this survey, this girl relapsed and had to go back into residential treatment. So those are some of the situations that we've found, that we've heard from our clients, that Insight has really been helpful. And now, Baki, if you can unmute yourself, I'd like you to talk about one of the patients that you found that Insight was very useful in helping in treatment, and just kind of talk us through what you saw and what ClearFork did as a result.
Okay, thank you, Joanne. And so thank you for everyone listening in. Here at ClearFork Academy, again, we work with teenage boys. We're primarily drug abuse program, but we have dual diagnosis programming to address kids who are coming in with the much deeper issues than the substances they're using. This is one of our clients who is here over the past quarter. We're a long-term program, and so we'll typically have kids here on average 76 days in treatment. And so once we get our initial survey established, and that's that black bar that you see on that left side of the screen or on each side of the scale, that's kind of the baseline of where they came in from their initial survey, and then you have the follow-up surveys. And part of what we do is we use this for real-time treatment engagement for each client as they're going through the program. And so each one of them will typically get this done weekly, unless we see that their case is a little more severe and they may need more common or more often surveys than once a week. And so as we track this, sorry for that, people was trying to get a hold of me. As we track them going through the system, each week our treatment team is looking at these surveys on where each client is at and tracking their progress through the program. We use the alert system to track for the suicide risk scale. So if they come in high severity on those scales for risk, our team is alerted right away, and then we have policies, procedures, safety protocols that come into place immediately when those happen. But for this particular client, what you'll see is oftentimes what they're reporting in their VISTA survey is incongruent for how they're presenting on the milieu. And so we use this as one thing. This is just to give us an idea of where their head is at. And then we use the subjective views of staff members who are looking at them, constantly doing visual assessments, engaging with them, the therapist interactions, and we're looking for congruency throughout their treatment. And when we see it's not occurring or it's not aligned, is when we decide how we're going to act regarding specific areas of treatment. If you look at this particular client around the same time on July 8th, you'll see that suddenly his scale dropped significantly. And at that time period, he kind of came to a point in treatment where parents and treatment team felt like he was being very superficial about what was going on with him in treatment. He was not really addressing deeper issues. And when we submitted an additional survey for him after that confrontation, that therapeutic confrontation with him, you'll see that suddenly all his scales jump to severe levels in most areas. And so what occurred when he dropped into those severe areas, we changed his treatment goals, changed his objectives real time. And then we continued to work through those things. And as we continued to do so, he came up with suicidality at one point, and we had to hospitalize him because now we were actually starting to see congruent behavior or congruent responses with what we were seeing in behaviors on the milieu versus what he was reporting. And so it gave us the ability to address what was truly going on with him at a deeper level, get him on some stabilization and medications, and then be able to treat him more appropriately for actual symptomology that was going on throughout his treatment. We really love that opportunity because it gives us the ability to change the actual treatment goals and objectives real time, not just waiting on that 30-day mark as it's supposed to. What it also helps us with is when we're doing concurrent reviews with our insurance providers who are covering these kids in treatment, we get to take this real data to them. And even though they may be behaving a certain way on the milieu, we get to document their actual self-assessments that say there's still levels of risk and concern with them. And so we're still needing to cover that and change our approach and objectives on how we're going to get to those specific issues. So it's actually helped us increase our length of stay for covered treatment with each of our clients as well. And when they ask for the actual evidence, we can print this off or set it up in a PDF and email it directly to that reviewer so they actually see the real scales, evidence-based scales, and the proof is right there in front of them. It's not argument. They're not able to argue it any further. And so it really helps in that area.
Can you talk just a little bit more about the congruency at the beginning? Like, it looks like he didn't realize he wasn't thinking he was depressed and then he became depressed, or he just wasn't aware of it? Or?
He wasn't aware of an understanding of depression, and he didn't have a clarity of how his psychosis, if you see that on that bottom right scale, he was not able to connect how his psychosis was playing into his severity of depression and anxiety and so forth. He had lived with psychosis for so long that he really just looked over it and really didn't pay attention to it. But in the milieu, when he was asked about it, he would report, no, I'm not seeing anything. I'm not hearing anything. I'm fine, and I don't need to be here, basically his continuous argument. But clients and staff were seeing him responding to internal stimuli. He was, speaking to things that weren't there at random times. And so there was clearly something off, but he, in his mind, I don't have a problem because this is the way I've always functioned. And then when he got an education and an understanding of, hey, this is what's actually going on, this is how it's impacting you, this is how it's impacting your social engagement with your peer groups and so on and so forth, he went through this series of understanding, like, okay, now I understand depression a lot more, and started reporting more congruently where he actually was, and it actually allowed us to apply medications to him that actually met him where he needed to be versus standard medication, which is I tell the doctor I'm not depressed, I'm fine, and I don't get any medication. I'm not sleeping, but I'm reporting that I am. Like those things that were all incongruent throughout his treatment, we were not able to see that. We were seeing it, but he was not verbalizing it. And so we had to build that congruence understanding for this is what's going on with you. This is what we see. This is what your scales are reporting. Where are we missing? What are we missing? And when we got that clear on the information, and we honestly sat there and showed the parents this as well, and they too themselves started being able to speak to it as well and say, well, yeah, we've seen him do that since he was 5. And that's always been his MO, and that's always how he's functioned. And when they had an understanding of it, they were more engaged in his treatment at that point as well, because we were actually able to show them evidence-based scales that say, this is what's happening with your son.
Wonderful. Wonderful. All right. What I'd like to do now is to move on to using the aggregated insight data to improve treatment effectiveness. And our new data analytics platform that we had our first beta testers like Baki using since April, but we've now just recently rolled it out to all of our clients. What it allows you to do is to analyze 30 different metrics in a number of different ways. You can look at them by program, by clinician, or by time period. So I want to stop now and go back to the website. And let's see, I'm going to go into our test drive again. And oops, I'm sorry, I have to log out of being a clinician and log in as a manager. Okay. Now I'm going to go to our data analytics site. And what you can see with data analytics is there's 5 different tabs. The first one is basic demographics. And what you can look at is gender, age, what brought them to treatment, where are they living? Are they living in a stable environment or not? Ethnicity, employment, are they working or going to school, or did they just, drop out? Marital status and education level. So that's basic demographics. The next tab is drug use history, what they tell us at intake. What is their primary drug of choice? And what is their addiction severity? So in the dark red, these are patients that report having all 11 of the DSM-5 symptoms of substance use disorder. We also ask motivation at intake, and this is something we haven't been reporting so much to clients up to this point. But what we ask patients is very early on in the intake, how motivated are you to stay alcohol and drug free? And fortunately, most patients will say, I'll do whatever it takes. There are some patients that will, say, yep, I want to use it in moderation, all the way down to, I can't wait to get out of here and use again. We also report number of previous substance use disorder treatments and whether they're using an opioid maintenance drug, and also whether they're using Vivitrol. At intake, we screen them and get intake readings for a number of different co-occurring disorders: depression, anxiety, trauma. We get records of how many times they've reported self-harming, and then also their suicidality in the month before treatment. And then the last 2 tabs are what's happening during treatment. So what you can see is the progress that patients are making during treatment. This chart shows the difference between the intake survey and the last treatment episode that patients filled out. So what you can see is that 72% of the patients came into treatment reporting moderate to severe levels of depression, and it decreased to 17% for their last survey prior to discharge. You can see the same information on anxiety and trauma, and then you can also see information on the last survey's suicidality, which fortunately is almost always dramatically improved from intake. And you can also see eating disorders, improvements in eating disorder behavior over the course of treatment. And then finally, the treatment completion tab shows you some information about their completion of treatment. So you can see your reason for discharge for the patients, what percentage successfully completed treatment versus left AMA. You can also see patient satisfaction with treatment. This is asked on every single survey except for the intake. And then when we, on the ongoing updates, we will ask, is this likely to be the last survey that you complete prior to leaving treatment? And if they say yes, then we ask them some other questions like, were you asked about your treatment goals, and were your treatment goals met? And we report that information here. So, as I said, you can look up information by center, by each of the different programs you have, by clinician name. You can look up by patient status, maybe looking at current patients only or just discharged patients. You can change the date the beginning date and the end date that you're looking at. And I think what you're going to find is this can be really useful. So before I turn it back to Baki to talk about how he's used this at ClearFork, I just wanted to show you a couple of examples. For example, let's say that you want to see how patient satisfaction changes. You might look at that for different programs. You might look at it just for your residential program. And what you might discover is only 53% are very satisfied. And you think, well, gosh, you know, I thought our total numbers were better than that. If you look at your IOP program, you find that, if I did that correctly, you find that you have much higher satisfaction rate. So maybe what you might want to do is dig into the comments that you're getting about your residential program and see if there is an ongoing issue that you might be able to correct that would improve patient satisfaction in residential. You also might find very interesting information, differences in the reason for discharge between programs. And sometimes you can find some significant differences in patient progress by clinician. For example, now we just put in all sorts of fake data here. So, but it was interesting just with the data that we put in, we could see between a couple of these pretend clinicians, you know, we took surveys and just de-identified them. We could see some pretty significant differences just between clinicians. So, for example, clinician Jen doesn't seem to be, seems to be having a lot of her patients complete treatment and still reporting pretty severe levels of depression, anxiety, and trauma. Versus another clinician, David, slowly. Among David, what we see is that he was far more effective in reducing the level of co-occurring disorders prior to discharge. So I'm going to turn this back to Baki, but this is probably a good time to tell you that we spent about, Baki, I'll stop sharing my screen so you can take it over. We spent 17 months developing this data analytics. What I thought might be a 6-month project at the beginning turned out to be much more complex to get in the security and everything else we needed to offer it to our clients. And so one of the things we've realized is that we need to start over and build the data analytics, rebuild it on a different platform that has a different interim database between our main software and the Tableau analytics. And so, we are offering it now to our clients because we know this information will be so useful. But I think you may have all sorts of ideas, and wouldn't it be neat if it did this, and wouldn't it be neat if it did that? And we will be incorporating a lot of those ideas, but not in the next couple of months, because we're going to be rebuilding the platform so that it doesn't take a long time to load, and so it scales more easily with all of our clients. So I have to ask you for a little bit of understanding that you're going to see some things you're going to say, wow, it'd be so cool if it did this, and we'd say yes, and we can't do it right now, but we're working on it. So anyway, Baki, back to you.
Awesome. Thank you, Joanne. So just some brief ideas or descriptions on how we use this. Just from the demographics page, for example, because we work with teenagers and we know how important school is for them as part of their success, I love that we have this highest education level piece in here because we get to have an understanding of how many of them are really truly engaged in their school, or at least it's important to them to be in school. And so we initially, our first year in the program, we had all of our clients on an online school program where they would spend 2 hours a day in school. But oftentimes we're not feeling like they had enough time as an opportunity to catch up in their school if they were really behind in their grades and so forth, or behind on their credits toward graduation. 2 hours a day wasn't enough. And so seeing that we wanted to improve that opportunity for our clients, we actually incorporated a charter school with our program now. And so we have a licensed charter school on site for our facility, which actually now gives our guys 4 hours a day of education with teachers present in the classroom, because that's something that was important to them to have versus just an online support person that they could speak to. And so we're hoping to see for this next year that this, just the highest education area of the education piece of our program will actually improve, and hopefully have some graduates coming from our program as a result of that implementation. So something that's important for them, so they don't have to go back to their school settings that were actually causing or the source of their use. So that's just one piece of how I use these. Another part, how I use demographics in general, and then also the drug use information, is I use this, I conduct a lot of CEUs around the metro Dallas-Fort Worth area. And so I use this education when I'm doing presentations with like the DEA, local schools, local providers who work in addiction, who are trying to get a real understanding of what the demographics are for use in our region. A lot of us, we hear typical drugs or some of the drugs because they're the hot topic drug to talk about. But when you really look at some of this data, it really tells you that the primary drug of choice for most adolescents in this metro is marijuana. Even though we're all focused on Xanax and higher levels or high risk drugs, most of them have a baseline use of marijuana. And so we might be focusing on the wrong substance in education and school systems. And so this is a big piece that I use for continued education throughout the metro and so forth. And this data gives me the ability to do that. And then also looking at what are their motivations coming in the door. We know, of course, not a lot of them, being teenagers, are motivated to come in and get sober. And so how we change our process and engaging with them out the door as soon as they get here, and we have to start off strong with them because we know their motivations are very low. And so we spend strategic time connecting and building relationships with them to establish a sense of motivation and progress for themselves versus what their parent wants or what the judge wants or what the school wants or the justice system wants for them. The question is, and a lot of our other assessments that we work with our clients is, well, what do you want to accomplish out of this situation that you didn't get a lot of choice in? And so what that does for us is it gives them a lot of opportunity for immediate buy-in. And that's not something we had or had a full understanding of before we had this. We just assumed, hey, you're here, sucks to be here. Now you're going to do treatment. But now we get to adjust it and say, well, what are you motivated to do? And so with that, understanding their motivations, we get to gear our treatment toward that. And then one of the other areas I like to talk about, is I'll jump through the rest of these. We use completion progress and the completion data for primary reasons like sales. It's a huge piece for sales. It's a huge piece for marketing. When people are asking, parents are asking, well, what are your outcomes? I'm going to make an investment in my kid being in your treatment center. How do I know they're going to have success, right? My kid's been depressed for the past 3 years and we've sent them everywhere under the sun. How do I know your program is going to be the one to do it? And the one thing I get to be able to say is, look, I have the data to say he has an 80% chance of leaving here without that depression. Even though he's been dealing with it for 3 different years, we can have an 80% chance rate of him leaving here without it. And so when you can make that argument to a parent, most programs can't say that with real-time data. And when they ask me for it, because some parents do, I can actually print them off the data and say, here's where we stand, and I can explain it to them. Sometimes I'll sit down with them and review it at the intake piece before they even sign the documents to place their kid with us. And I'll say, this is what we do. These are the outcomes that our program secures for your client. And so it comes with your engagement, it comes with your participation, following the curriculum, following the recommendations of the treatment team, and your success rates are going to have a really good chance with us. Okay. As far as programming, the areas for treatment goals, reasons for discharge is a big one for us. I really hate AMAs. Okay. They're never good. They're never good for the client. They're not good for the program. There's always some level of risk in there. And the client, the family, the therapist, everyone who's involved with that kid all leave feeling very unsettled when a kid leaves that way. And so One thing that we're strategically working on is decreasing the AMA rate. And part of that is in our performance improvement was spending strategic time educating our team, first of all, what constitutes an AMA by our definition as a program, right? We're not necessarily dealing with imminent risk kids, so we don't have to worry about them immediately leaving here and falling to suicide, but we do have to worry about them leaving here with high desires and urges to use is a risk concern for them returning home that leads to other potential risks. And so we created performance improvement and outlined definitions of what discharge criteria looks like, and how do we streamline our communication to families as well as within our system to what a discharge actually is, what an AMA actually is. But also it helps us engage with families in a different way versus, hey, I just want my kid because we feel better about him going. We get to establish a process that says now, look, because of these risk factors, because of what's still on the table, because of the treatment problems that haven't been resolved, here's what we need to establish in place for his continued well-being. And here's how we need you to engage in these. We need these appointments to meet these sort of needs. And we need them at this time. And we need to have the ROI so we can submit their clinical and presentation to that provider. And we need to have that conversation with that provider so they know what they're getting and where they get started with that kid when they return to that community. And that, because we know that that client is leaving with services established for him, it gives us the ability to say, okay, it may not necessarily be a successful discharge, but he's met the requirements of some of these levels of his treatment, and we don't have to leave him here. He's not going without services, so it's not technically an AMA. He's going at parent request, and parents have established services in place to continue to meet those needs. As far as satisfaction with treatment, that's something we track as well, right? And that's something we always want to pay attention to. We have a case manager who's looking at the notes from the clients who, after they complete each survey, and his immediate process is to follow through with them real time again and look at what is the satisfaction. If there's something I'm disgruntled or have a grievance about, can we resolve this immediately versus having this issue continually showing up in their surveys throughout treatment because it hasn't been responded to or it hasn't been addressed. And we go through a formal process of addressing it. It's a grievance now. We want to resolve it. We want to make sure the client feels resolved in it. And so then they do that next survey, we'll hopefully see a little higher satisfaction in that treatment area. Now, again, because we work with adolescents, sometimes their dissatisfaction with treatment is the sheer fact that their parent has them here. And so that's a whole nother battle that we work through, but at least gives us an idea of what we're dealing with, especially if it's a result of the actual program itself. And then the last thing I'll touch on, if I have a minute to, Joanne.
Absolutely.
When we're talking about treatment goals and their knowledge of treatment goals, I essentially, I would like to have at least 90%. Our goal as a program is to have 90% of our clients having a complete knowledge and understanding of their treatment goals, okay? In our treatment plans, every single one of our clients' treatment plans are written out to specifically state that they will meet 90% of their treatment plan goals in order to successfully discharge from the program. So that means they have to know at least 90% of their goals in order to meet those goals. And so it's created our performance improvement process to strategically outline and make sure it's very clear that the clients are aware of their goals. They know what goals they're accomplishing each week. We have a Tuesday ceremony that we celebrate their goals and their accomplishments each week. And then when they leave here, now we've implemented the process of, hey, here's the goals that you addressed while you were here. Here's what you got to. This is your last survey. Let's have an outcome, or let's have you complete this, understanding that you know what goals you've met, you know what you've accomplished, your therapist reviewed that with you. Here's your last survey before you discharge from the program. And so those are just performance adjustments that we made in our system, policies, procedures that we've made in our systems as a result of being able to have access to this data and know what's actually going on with our clients.
Fantastic. All right, I'm going to share my screen and finish up with the presentation, and then we're going to open it up for questions. So the last thing that I wanted to cover was how you can use this aggregated data to create a performance improvement plan. And obviously, all treatment centers will have opportunities to improve. Every company, every person has opportunities to improve. And the wonderful thing about now having this aggregated data is that you can determine how you're looking versus other similar treatment programs. You can set specific goals on how to improve, and then you can measure your performance towards those. So that is something that the Joint Commission is asking for. That's also what CARF asks for in terms of their performance improvement plans. It's also, of course, the right thing to do for any center that wants to be continually improving what they're doing. So I set up just a very simplistic way that you can, a process you can follow to do strategic planning and come up with a performance improvement plan. The first thing I would recommend that you do is compare your data to the norms for other treatment centers in the VISTA Research Network, and see what's different. So just looking at, this is the data, it's about 5 months old. We're in the process of updating the norms again to provide it, but this is based on 15,000 patients, and you will notice a very significant difference with this data versus Baki's data. And in terms of, this is showing that the primary drugs of choice are alcohol, heroin, and opiates. And only 6% marijuana, versus Baki was showing us that it was about 2/3 marijuana in his adolescent treatment center. So that kind of points up the importance of looking at norms among similar types of treatment centers, which we will be doing more and more of as our base of clients and our base of patients grows. But maybe what you would look at, maybe if you had found, for example, that among your population you had 25% heroin and 20% opiates, that, what you're focusing on, that is an important thing that you could communicate to payers or prospective patients, that, we focus pretty heavily on these two areas, which could help you recruit more patients with that particular disorder. It'll also allow you to identify what you're doing particularly well and possible areas for improvement. One of the challenges that we've seen just in providing these numbers is that most treatment centers' results look very positive if you don't have anything to compare it to. I've talked to a number of different centers that would have, say, 60% patient satisfaction in an adult population, and that, 60% saying my patients are very satisfied, and, maybe 85% very plus somewhat satisfied. And that sounds really good. But if you compare it to our norms, that actually puts them down in the bottom 20% of adult treatment centers. So once they are able to identify that actually among adult treatment centers, those norms are, your numbers are substantially less than the norms, then they become, more interested in digging into the patient comments or just trying to figure out what else could be done to improve satisfaction and bring it closer to the norm for our type of treatment center. Once you have identified what you're doing particularly well and some possible areas for improvement, we recommend that you choose 2 or 3 areas that you want to focus on improving. And then you brainstorm in a very open fashion. What are some different things that we could do to improve? And the objective here is to go beyond the obvious and just kind of start throwing out some wild and crazy ideas, because often they will contain a kernel of something that's really useful. Then what we suggest is that you set specific goals and determine exactly what you're going to do to accomplish them. So we've gone through this process with, I think, a couple dozen treatment centers at different outcome summits and in a few individual sessions, where the objective is to come up with 1 to 3 different goals where the treatment center says specifically what they want to accomplish and put numbers and time frame behind it. So, for example, we want to decrease the level of AMAs from 18% to 15% by December 31st. 2019, for example, and what specifically you're going to do to try and do that, and write it all out, get a buy-in to the strategic plan, and then obviously review how you're doing against those goals on a regular basis. So anyway, I want to thank everyone very much for attending, and fortunately we have about 15 minutes left for questions. And so if you have a question, please unmute yourself and maybe show the camera if you're on camera, but at least unmute yourself so that we can hear your questions. So Alec, okay, I see Alec is up and his group. What's your question, Alec?
I have a ton, which I will ask you separately for the sake of time. But the one question that I did want to ask, you said the data that is aggregated for the analytics is de-identified. Is there a way to re-identify that data if we wanted to look at like a troublesome population or see why people were very dissatisfied and maybe look at reasons or progress notes or something like that?
I didn't mean to imply that your data is totally de-identified. What I meant was that in the test drive, it was faked.
Okay.
But, you know, what we would really love to be able to do, and let's see if I can go back to our test drive. What I would really love to be able to do is to click on a segment like the people who are very dissatisfied. We would like to be able to click on that, pull up the IDs for you of the patients that are very unsatisfied, possibly even show you the comments they're making, so that you can, you know, really wrap your mind around, you know, what is causing them to be so dissatisfied. That is one of the things I'm telling you that we want to do. We cannot do with this workbook. It should be, I hope, part of the next workbook, which we're hoping, I mean, I'm pretty confident we'll have it before the end of the year, but unfortunately that's one of the areas that we're going to have to ask for patience. But any suggestions you have for things like that, we would, you know, please make sure that you let us know. You know, another thing that we would like to be able to do, for example, is to be able to go to the drug use and maybe click on a segment and say, okay, just among the heroin addicts, how do their results differ? And again, that's something we can't currently do, but it's in the long-term game plan.
Awesome, thank you.
And Ryan, I saw that you raised your hand with a question. What's your question, Ryan?
Hi, how are you?
Good.
It was a question in regards to satisfaction as well. One thing that we notice is that a lot of our clients are asked on the Likert scale how satisfied they are with treatment. And their number 3, the option is neutral. We're running into an issue where a good amount of our clients are coming in and they're being assessed upon intake, and they're not really sure how they feel about the program yet, so they select neutral. I'm sure there's always a level of controversy in regards to a neutral test point. I've seen scales where they just omit that question or that result if they select neutral. What's your stance on that, and how can we work around that?
Well, we don't see a large number of people selecting neutral, so I would prefer not to change that scale, but I will also tell you that we don't ask patient satisfaction on the intake survey.
Understood.
Obviously, they don't know whether they're going to be satisfied with treatment yet if they've just arrived there. So the patient satisfaction is only asked on the ongoing surveys. So I don't think you should have that kind of problem.
We may run into it being that we're a step-down receiving facility. So now that they do their intake at, let's say, our higher levels of care, Stewart and Boca, it may be something when they first come into our facility that they may not be sure how they feel at the PHP or IOP level of care.
That's possible. Yeah. You know, we're not finding that there's a large number of people selecting neutral. I mean, if you just think back to that norm that I set, you know, it's only a couple percent that are typically reporting neutral. So I don't think that it's I don't think we have to change the scale to
No, I don't think so. Maybe perhaps having a separate intake, or you're saying it's not done during intake.
It's not asked on the intake at all.
Okay, just wanted to see if there was any sort of way to avoid that loophole or that trap of having neutral, because I think it'll decrease our level of scores from very satisfied.
How do you guys generate the score for very satisfied or somewhat satisfied? Do you take an average of what they say over time, or do you go with their most recent or the highest?
With patient satisfaction, it's just an average of all of the different surveys that were reported that were submitted during that time period. So, you know, if you had one patient that submitted 10 surveys who loved it and one patient who submitted one survey who hated it, you know, you're going to get a very high score, right? It's not by patient, and it's just an overall average.
So what I'm getting at though is, like, if a client comes in and is feeling miserable and they're rating us as unsatisfied, and then toward the end they start to build a connection with their therapist, medications are working, they're feeling better physically, and they're like, actually, you know what, this place isn't bad, I really am satisfied. I think that those first initial very dissatisfied are going to drag down the fact that they were eventually satisfied at the end of their treatment stay. They might not have realized that they were satisfied until they spoke to their mother, who said, I noticed the change in you, I'm so proud of you, something like that. I think that by just taking all those surveys and averaging a number, we're not really getting credit that's due.
I see. Well, remember, you can look at, oh, I'm sorry, Baki, and let me let you answer in a moment, but remember that you can look at satisfaction as a function of how long patients have been in treatment on the group summary reports, and you can see if that changes. I would have to say, having looked at, I don't know how many zillion different reports over the last 3 years, that it's not uncommon to see a dip in the middle, maybe, as you know, you're really getting to the work of treatment. You know, it's hard work to recover and to, you know, change how you've been acting and thinking about things. So if I were to say anything, it would be that, you know, satisfaction tends to be higher at the beginning, dip a little bit in the middle, and then end up higher. But, you know, that's something that we will definitely look at and see if we do see trends like that. Because, you know, obviously we're creating a large data set of data that, you know, can be very useful for exactly that sort of analysis. Anyway, Baki, what were you going to add?
And I don't know if this will help with some of the questions they're asking, but part of what we do is our case manager follows up with those dissatisfied marks in treatment and tries to establish a narrative to those for them in our documentation and in their health record. As part of that follow-up, because sometimes what they're dissatisfied about isn't necessarily the treatment itself. It's something external. It could have been a phone call that went bad, or just maybe an interaction that was wrong with a peer, or it could be staff related. And so we try to tease that down and get an exact understanding of that and then document to it, because sometimes it's not necessarily treatment, but an event that happened in treatment, if that makes sense.
Right, definitely. So, I mean, I think for the most part, clients they don't really hide when they're dissatisfied. They're very open and vocal when there's something they're not happy about. But we do look at our numbers and we take our satisfaction scores seriously. And one thing Joanna was saying was using these numbers for potential payers or marketing. So I think, like, if a client does rate as dissatisfied and they meet with a case manager, the therapist, and they say, I'm dissatisfied because the cable went out last night in the middle of the sports game or something like that. Like had nothing to do with like treatment in general. In that moment, they were just upset, which happens a lot. We get complaints about the cable, and they wanted to watch like the fight and stuff like that. And I think that if we wanted to report our numbers based on Vista Analytics, I think a lot of that would be underreported based on overall satisfaction, because we do our own exit surveys, and our numbers seem to be significantly higher than what Vista Analytics say. And I think it's because of that purpose, the random sampling and taking into account every data point rather than the most recent or the latest one.
You know what, we'd be happy to look at that for you, because I know we've had this discussion several times, but I'd also say that a significant difference between those two types of data is that when your patient is submitting an exit survey, you're sitting there. I mean, they know somebody is going to look at it right away. You know, I mean, in other words, it's, you know, you're being asked to do that, you know, by a treatment center personnel, versus ours is, I think there's more of a comfort maybe for telling the truth on a survey where you're on the internet. But anyway, we can find that out for you. I mean, we analyze an awful lot of things by, you know, the difference between intake and last survey, and we can definitely look and see if you know, if there's a difference between first survey and last survey for you, if that would be helpful.
Okay. And at some other point, if we meet, I'd be more than happy to share my data with you that I collect, which we do compare intake and discharge. So I think you'd find that interesting.
Okay, I would love to see that. Okay, excellent. Do we have, I think we have time for one last question. Does anyone else have a burning question out there? All right, well, let me wrap up. I will tell you, as I mentioned, it's really important to compare your results to norms. We are in the process of updating the Vista.
Hey, I'm sorry, Joanna, it's Kalia in
Oh,
Boca.
hi.
Hey, I was trying to follow along when you were showing us the analytics, and in our system, it just says no data available. Is the analytics, is that going to be accessible to the directors, or is that just something that like you and your team use?
Oh no, you should have this, but you know, there's a certain number of data analytics seats, and each treatment center tells us who they want to have access to the data analytics, and it's possible that you know, for whatever reason you weren't on the list, but we can add that. But yes, it's supposed to be, you know, right now, if you look at my screen, if you have a tab down here, that's how you access the analytics for your own treatment center. And, you know, I know that we had some issues with getting the right centers matched up with different things earlier this week, and maybe it's been fixed now. But if you could reach out to us afterwards and let us know if it's not still fixed, we will we'll look into that for you. So
yeah, I think that I just think that would be helpful for us to be able to utilize that kind of in real time, because I know that we receive these reports from you guys, I think usually quarterly, but I did not realize that they were just accessible in the analytics tab to us.
Yes, you can, and you can slice and dice by clinician, by program, by time frame. It's, you know, you can do with the data analytics so much more than when we're presenting just an aggregated report at the end of the year. You can use this.
Yeah, I noticed that. That was really good to see in this training. I'll talk to Keith over here about that and see if that's something that, oh my God, Keith just texted me.
Anyway, let me just finish with thanks, Kalia. Let me just finish and say that we will be publishing the latest norms in the next couple of weeks. We'll be putting out a blog post that talks about the importance of benchmarking against norms, and will allow you to download the latest norms. If you need them earlier than that, we have norms as of March 31st, and reach out for us, and we'd be happy to send that to you. So anyway, I want to thank Baki very, very much for coming on and explaining how he's used the information, and really appreciate, Baki, you taking the time to explain what you do and let other people learn from your experiences. And I want to thank everyone for joining us. And thank you very much. This webinar should be available, recorded version, in a couple of days. So we'll let you know if you have anyone else you think should see it and wasn't able to join this. So thank you so much, everyone.
Thank you.
All right, thank you.
Bye-bye.